So our next topic here is brain metastases. So obviously this is, as systemic therapies are getting better, and some of them, but not all of them, have brain penetration. I think this is becoming more and more an issue for us. So let's move on to this. Some epidemiology again. There are 170,000 brain mets cases annually, and I think that's increasing now even more so. Most 20 to 40% of cancer patients develop brain metastasis. 20%, 25% dying from cancer have brain metastasis at autopsy. 15% of those are parenchymal. 60% with lung and breast cancer die with brain mets. So 125,000 of 200,000 patients are in that situation. In a ratio of metastasis to primary are increasing. So again, this is better systemic control, but the CNS remains a sanctuary site. On top of that, there are better diagnostic imaging that sees these before even they could become symptomatic. So this is kind of an exploding problem, if you will, and it's a problem due to better systemic control agents with still some sanctuary site available, or preventing some agents from getting into the brain that might otherwise have activity against brain mets if they could get there.
Dr.
So,
Swanson,
yes.
there is a question. Someone put a couple questions in. I think that was from the previous.
Yeah, I think I talked about them. I think we're
No, someone just added something
in the chat. Okay. So okay. So the first set of from the that I kind of talked about, just so you know, from the diffuse midline gliomas, I was talking through offering the information as it was so I will try to do that. There is a question now about hydroxychloroquine in glioblastoma patients, and I would say that I don't think that that's something that I would worry too much about. There are lots of different things, herpes viruses that are thought to be involved in this, other things that I wouldn't expect hydroxychloroquine to be something that would be testable. Just so you know, I'll try to watch the questions and read them from here on out. Okay, so moving back to the brain mets. The acronyms for the most common contributors to brain metastasis is pounds, kilograms. So that's lung, breast, skin for melanoma. Okay, kidney or unknown, and GI. It is rare in prostate, oropharynx, and non-melanoma skin cancer. I have to tell you, however, though, that now that the treatments are getting better for prostate cancer, I see a lot more prostate brain mets. And I see a lot of times that once they undergo neuroendocrine differentiation, you can see that. And I think as oropharynx and non-melanomas, even though it's rare, again, because patients are doing doing well longer, I think that the incidence is going up, even though they are still rare. Children, the most common causes of brain metastasis under 10 years old, neuroblastoma and rhabdomyosarcoma, and osteogenic tumors in this early teen, and then older children, germ cell tumors. So most of the tumors that you see are within the cerebral hemispheres, and then followed by the cerebellum and brainstem. I think that's as much a function of how much blood supply each of these things help and they generally end up seeding in the terminal arterioles of the gray-white interface. 1/3 are solitary, 1/3 are oligometastatic, and 1/3 are of brain mets are more than 4 metastases at presentation. Pelvic GI, there might be some differences. 50% are solitary and posterior fossa mets versus 10% in other cancers, whereas in lung and breast, there's an equal real estate distribution there. 2/3 are symptomatic, although incidence early detection is asymptomatic metastasis by virtue of having routine imaging as part of staging. One interesting thing that might come up is even though we see that that renal cell is a sizable contributor to brain metastasis, except for in aggressive histologies or extremely advanced disease, a brain MR is not part of the normal staging workup of renal cell cancer. So that's an interesting thing. The symptoms are somewhat referable to where they are, but cardinal symptoms of increased intracranial pressure, headaches, focal neurologic dysfunctions, cognitive changes, seizures, or strokes are presenting features of brain metastasis. Again, headaches, increased intracranial pressure, nausea, vomiting, vision changes. The headaches are described as dull, throbbing, and generally unilateral, more than diffuse, and more common with multiple metastases and those in the posterior fossa. Patients, one kind of maybe urban legend thing is that they have their headaches are more common in the morning or worsening with straining. This is actually an uncommon presentation. Patients present with cognitive and mental status changes. I've had a patient who they had lung cancer and he started smoking like 8 to 10 cigarettes at one time, and people thought it was really weird. And those are the kind of things that could happen, as crazy as it sounds. Focal neurologic symptoms, hemiparesis is the most common, and you can have seizures. Very small metastasis can provoke a stroke if it's in the irritable location in the brain, like in the motor strip. Strokes can happen due to tumor emboli, and then hemorrhagic metastasis are often associated with various histologic subtypes. Melanoma is very commonly known to bleed, thyroid, renal cell, and choriocarcinoma. So all of these clinical presentations could give you a hint as to what you may be dealing with, even if a patient presents with de novo brain metastasis. So the diagnosis of it: contrast enhanced multiplanar MRI. This is because the brain metastasis disrupts the blood-brain barrier. The flare sequences, again, fluid attenuated inversion recovery, can show edema. It represses the CSF signal so that what you're seeing is, say, intraparenchymal fluid. Again, it could be due to tumor infiltration, but with brain mets, more often it's a function of edema or swelling, inflammation around the tumor. Radiologic features that may bend you on the differential to a brain met, enhancing if they're multiple versus solitary, if they're at the gray-white junction, Generally, they have a nice circular morphology, and they expand, and they're associated with edema. Biopsy is rarely needed for synchronous or metastasis presentation. So, obviously, next year when you see brain metastasis on your someone present with de novo brain metastasis, it's not inappropriate after you get an MRI of the brain to get systemic imaging, because there might be a reasonable biopsiable target, maybe one that is less has less risk to the patients, so you can biopsy it from there. The CSF and spinal evaluation for dural-based lesions, I would say not necessarily dural, but we'll talk about leptomeningeal disease a little bit later on in this presentation. So this is what the T1 contrast looks like, a nice circular lesion at the gray-white junction. And then if you look at the flare, this is where you see the adjacent edema incited by the in this case, single metastasis. The differential diagnosis is important, and I think that even next year you're going to want to be able to regurgitate some of the differential of this. This is Dr. Magic L is a good acronym for demyelinating disease, radionecrosis or resolving hematoma, metastasis, abscess, glioblastoma multiforme, or a high-grade glioma. You can have an infarct that you may have some contrast changes in the subacute phase, a contusion, and a primary or CNS lymphoma. Sometimes brain metastases are due to when you don't have the primary. So just so you know, the incidence of a solitary is about the same as multiple. Here's the deal: a single metastasis is when you have some disease in the body, and then you have one brain metastasis. A solitary brain metastasis is when you have a lesion in your brain, and that's the only one that you see, and it's metastatic. Okay. 2/3 of unknown primary brain metastasis are supratentorial, and of them, 2/3 of these are in the parietal area. 60% of them ultimately end up being lung primaries, with 15% other primaries. And then there is a sizable population, up to a quarter of them, that have brain metastasis, and perhaps in this case, truly a solitary metastasis in which there is no known primary. Workup includes, and this will be part of your scripting for next year, I'd like to do a complete history and physical examination, concentrating on the neurologic exams, looking for this, that, and the other thing, symptoms, length, duration, things like that. It's important to know about smoking history, things like that, and when the workup. As you're waiting, it's not inappropriate, again, to get other imaging studies like CT scan or chest X-ray or mammogram if you're looking for a primary site. Tumor markers, however, are rarely useful in the identification of what on presentation may seem to be an unknown primary. So there's lots of ways to manage this, and these are just general ways. Surgery versus radiation, and that radiation can be in the varieties of whole brain radiation or stereotactic radiosurgery, or chemotherapy. That's becoming more common for small brain mets for patients with targetable disease and therapeutic options that have access across the blood-brain barrier. symptomatic treatments with dexamethasone, anti-seizure medications, and analgesics, and then supportive care is that depending on the overall clinical picture and the patient's performance and disease burden. We'll look at this when we look at the court study, by the way. So the goals of treatment are to control neurologic symptoms and increase survival. Honestly, if you look at NCCN and most institutions, when your primary lesion gets to be above about 3 centimeters, or 2 to 3 centimeters even, and it is surgically accessible, it's quite reasonable for surgery to be the principal goal if it can be completed. But there are many things that affect treatment outcomes: age of the patient's, performance status, and neurologic symptoms, whether they're single versus multiple lesions, and the extent of systemic disease in response to therapy. In fact, there have been attempts to identify what we call recursor partition analysis. In fact, early ones developed by the RTOG gave us some ideas, but they did not account for history or size of the tumor, or location of the lesion, or the number of lesions, or the extent of treatment response or treatment response. And so there's been a emphasis on attempting to tailor recursor partition analysis building on outcomes from various studies. And so there is a graded prognostic assessment. This includes for lung cancer, KPS, age, extracranial disease, number of metastases. You can see breast cancer has one, melanoma and renal cell carcinoma and GI all have different things that make up their as the acronym goes, their GPA. And this is prognostic, because you can see that we look at the overall survival. Patients who have a GPA of 2.5 to 3, or to 3.5 to 4, actually can live quite some time. And this is for different histologies here, just so you see that A is for breast, right? B is non-small cell lung cancer. C is small cell lung cancer. Renal cell and GI. So the shape of these things are different, as are although they all kind of here terminate at three years, because that's what they looked at in this particular study here. But it's very hard to prognosticate these days for brain mets because of all the different agents that are being used. I mean, even that you could fathom where the breast would separate out based on HER2 status, or non-small cell lung cancer based on their PD-L1 status and things like that. So the more we learn, we have to learn more, right? And that's kind of I guess that's a good thing, right? So anyway, so just looking at supportive care alone, this is early data when there wasn't a lot of options that patients had. If you're going to give dexamethasone, usually it's 4 milligrams Q6 hours, and you can give a 10 milligram loading dose. A lot of times when patients come into the ER and they're not really sure what's going on, that they're symptomatic, patients are often loaded. Sometimes they're even given these things, and then it takes a long time for a radiation oncologist to come on board and start managing their steroids, which sometimes are god awful high, out of a concern for medical legal more than anything else. Side effects are not trivial with high dose and even long-term dexamethasone, GI, ulceration, immunosuppression, glucose intolerance. Patients with brain mets, they're weak, and then they find out that, well, it's because they've been on dexamethasone for so long. Anti-seizure medications, This is another bane of our existence. Patients get parked on anti-seizure medications out of probably devotion to medical legal issues, but at the same time, the data is just not there. Only if they've had a seizure, and then a patient will be put on a anti-seizure medication. You ask them if they ever had a seizure, they say no, and then they want to know if you can take them off their anti-seizure medicine so they can drive. I usually try to send that back to the person who put them on them in the first place. Methylphenidate and the Znaprazil, these are there is some data for improved alertness with these types of drugs. Median survival of patients with brain mets that are untreated is pretty poor, usually about 4 weeks. So there are early studies of supportive care versus whole brain radiation therapy. The early 1954. I mean, it's very rare that you'll see citations that old. But there was a randomized trial that showed a survival benefit by 2 to 4-fold. So if we're looking at median survival of 4 weeks, and you can get them to live 4 months, that's a pretty significant improvement. Indications for whole brain radiation therapy, and this is an ever evolving kind of hurdle. So in general, if patients have multiple metastasis, and the term multiple always seems to grow. I think it's, I think some of the initial trials, as we said, would look at 1 to 3 metastasis. And then I think that NCCN says maybe up to 10. I've treated as many as 23 at one time. That doesn't mean, I think there's a real personalization of brain metastasis management in this setting of an era of that's rapidly providing, new drugs with new CNS activity all the time. But it will see it's very appropriate for people with leptomeningeal or cranial spinal disease. We've seen all kinds of different fractionations for brain mets. You can see there's 40 gray given over 4 weeks has equivalent survival to the gray given in 1 week. So, we still stick kind of with the 30 and 10, but for poor performing patients, 20 gray in 1 week, although it may increase the need for steroids, that it may improve their quality of life because less of the time left here is devoted to a therapy that is not curative. Like I said, whole brain radiation generally can increase the overall survival from 1 to 2 months to 3 to 6 months, and 10 to 15% of patients with who are treated with whole brain radiation could have a 1-year survival. It's really good. This is important to know. The first palliative care doctors were radiation therapists, right? And so there's a 50 to 80% response rates for neurologic symptoms, better if they're headache than if it's cranial nerve disease. I always try to set I think that the biggest thing of physician-patient relationship is reality meeting expectations. So, I always tell my patients, well, I don't know if you're going to improve during the treatment, but in the 1 to 2 weeks afterwards, that will there's a good chance that you will have some resolution of your symptoms. Okay, 70-80% remaining life is stable with improved neurologic symptoms. So as unsexy as whole brain radiation therapy seems to be, it certainly has a lot of benefits for select patients. Okay, it decreases the likelihood of death from neurologic causes. Okay, and it really starts to go back and forth between. What happens all the time is this: you have nothing that gets in the brain, and systemic disease is not that good. So then you start dying of intracranial disease, and then the treatments for intracranial disease get better, and the systemic disease is what they die of, and then the systemic treatment gets better. So then all of a sudden it's intracranial disease that they die from. So there's a kind of a ping pong back and forth between that, and nowhere are we seeing that more than now, in such almost lightning speed compared to eras before. Lung and breast tend to respond better. Breast responds very well to that, and lung, particularly if it's small cell lung cancer. It's more the durability of response, rather the response itself. Technically, those disease sites that are considered radio resistance have worse outcomes. Melanoma, GI tumors are really bad. Renal cell carcinoma. It's probably the earlier the treatment, the better, but obviously we don't have studies to show that kind of stuff. So like I said, RTOG 7006 looked at dose escalation. We've looked at hypofractionation. We've looked at shorter courses. We've looked at altered fractionation. We've looked at radiosensitization. Pretty much all of them have not been shown to improve really anything. So, you can skin the cat anyway. It's not going to get a better thing, but in general, 30 gray and 10 is the standard, 20 and 5 if you have poor prognostic patients. The toxicities of whole brain radiation therapy: skin irritation, alopecia, fatigue, increased steroid intake, neurocognitive deficits. So we're going to look at that more, but a lot of it is extrapolated from pediatric and glioma literature. DeAngelis with the induced dementia, recurrent brain tumors are more likely to cause dementia as well, or so the risk versus benefits are there. The PCI data for small cell lung cancer do not clearly suggest increased dementia incidence, but again, those patients were pretty heavily treated with chemotherapy, and that's always something that's got to be taken into concern, even though we have all these fancy terms for neurocognition. The term chemo brain is not a trivial one. So there was a study relatively recently published in Lancet. Large managed health systems like that in the UK and Australia, they're interested in saving money, right? Or at least not spending money unless it provides some kind of, it's an efficient benefit. So they had limited resources, right? So hey, so do we need to even treat patients with whole brain radiation? Okay, so in this case, 538 patients were randomized to whole brain radiation plus supportive care versus supportive care alone. Okay, there's no difference in overall survival, no difference in quality of life, and no difference in dexamethasone use over the entire cohort. Okay, so the interpretations of this study that hit the press were that whole brain radiation therapy no good for this is actually what the headlines were. Okay, whole brain radiation no good for metastasizing lung cancer. Whole brain radiation ineffective for lung cancer with brain mets. Brain radiotherapy no benefit for lung cancer patients. Okay. Little benefit reported with whole brain in non-small cell lung cancer with brain mets, unsuitable for resection or stereotactic radiosurgery. So these are patients with whole brain radiation with metastasis due to non-small cell lung cancer. So this is this is based on the primary endpoint for that, right? But if we look at the forest plots, and it's probably worth knowing that this is what a forest plot is. It shows those situations that favor one treatment or the other. So if you had a good performance status, like greater than, if you were older, you actually favored supportive care only. But if you're younger patients less than 60 actually derived a significant benefit from whole brain radiation therapy. If you had more than 5 metastases, you had a benefit from whole brain radiation therapy. If you had, a relatively good GPA, you improve. So I think that this is the outcomes for this, or the no difference in survival. That's all comers. No difference in quality of life. That's the problem. Is that there are clearly patients. That benefited from it. So this is what happens when studies are done and they hit the press and they're not really well scrutinized. So I would say that getting rid of whole brain radiation therapy for brain metastasis would like getting rid of baby with the bathwater. Looking a little bit further, the rationale for surgery for whole brain for brain mets is that the brain mets are often solitary and local in nature. Whole brain radiation is inadequate for local control, and surgery can more rapidly control the mass effect, hemorrhage, and all those things that might result in symptoms. Time to progression is significantly improved with surgery over nothing. However, it does carry with it the operative risks and mortality and morbidity. So this is the landmark Patchell study that showed a benefit to whole brain radiation to surgery versus surgery alone. You can see that there's an improvement in median survival with the addition of radiation, improved overall survival, decreased local recurrence. So this is and functionally independent. So this is Patchell's study was the thing that formed the foundation for whole brain radiation therapy after surgery for even a single brain met. There were 2 other trials that showed that showed a mixed response here, but the RTOG showed benefit to surgery plus radiation. Again, when you look at all comers versus prognostic factors, patients who had young age, no or stable extracranial disease, and longer time to develop extracranial disease did get a benefit from whole brain radiation after surgery. Okay, so again, this is the surgery plus whole brain versus whole brain alone. So you want to take it out if you can. Okay. So more data on this, on the surgery plus whole brain for single metastasis. Okay. This is the Patchell study. So again, just another slide on the Patchell study. This is a summary, I'm sorry, of the Quartz trial. Patients with brain metastasis from non-small cell lung cancer were randomly allocated to either optimal supportive care, so including dexamethasone. Okay, there was no significant overall survival for randomization. This is the only large randomized trial evaluating the utility of whole brain radiation therapy in the disease. But again, this is a repeat slide here. Then we talk about SRS. So this is where we are now, right, these days. Most METs are small, spherical, they have distinct margins, and they displace rather than infiltrate. the probability is probably equal to or greater than surgery for local control, and it's more cost effective. Although there is no comparison to surgery plus or minus whole brain radiation therapy. So that study will probably never be done, right? SRS advantages over surgery, its availability. It's a 1-day patient procedure, although, now with fractionated regimens, that may not be true. You can treat multiple lesions. You can treat lesions that are inaccessible, and the dose, the distribution of your dose is more conformal, and obviously there's no surgical morbidity or mortality associated with SRS. So this is a cataloging, if you will, of retrospective data using SRS, and the doses here and the local control. These are retrospective data. So we look more at randomized studies here. So if we look at Kanzioka, he's a gamma knife versus, so we look at SRS versus SRS plus radiation therapy versus radiation therapy alone, the median survival, local control, relative relapse. You can see here adding whole brain radiation therapy to SRS seems like it might have some benefit in certain circumstances. Then we enter into some trials, and RTOG 9005 really was the landmark study that sets the doses for tumors. So this was a dose escalation study, and this was a maximally tolerated dose, which, by the way, was not reached in this study. So, but usually most places use the ceiling of 24 gray for lesions less than 2 centimeters, 18 gray for those 2 to 3 centimeters, and 15 gray for 3 to 4 centimeters. Although, quite frankly, people aren't doing this I don't really see a lot of 15 gray SRS. In that case, it's fractionated. We'll talk about that coming up here soon. RTOG 9501 was whole brain plus or minus radiosurgery for 1 to 3 Mets. Okay, so all patients had increased KPS, increased local control, and decreased steroid use. But we look at some of these. So 9508. They got 37.5 whole brain radiation plus or minus SRS. Okay, and the SRS was based on these doses here from 9005. And the the SRS was delivered by GK or LINAC. Surgery and crossover were allowed. So we look at outcomes here. Okay, so overall survival was not statistically significant whether you added whole brain radiation therapy to SRS alone. Survival, so survival again was and histologic status we look at here. There was a difference in this. So the summary of this is there was increased local control and quality of life, but no increase in overall survival. Okay, there was the 6.5% of months for whole brain radiation therapy plus SRS versus 5.7 months radiation therapy alone. Okay, 20% randomized to SRS did not receive SRS. 30% of whole brain, percent with whole brain, only patients crossed over to whole brain plus SRS. Okay, so the rate of CNS death was the same in both. Okay, but a criticism of this is that it showed the best local control for whole brain radiation therapy ever reported at 71% at 1 year. Other SRS trials We looked at increased local control, okay, and less distant brain failure when they added whole brain radiation therapy. This all seems to make sense. Is that, you know, radiation, the SRS is not expected to control disease that is considered other brain failure. The question is the disease that you're looking at likely to have other brain failure? And if in a situation where you can come back and do repeat SRS, is it really worth committing the patient to all the toxicity? And we'll look at that here. Okay, we look at the IOMA study here, that for whole brain plus SRS versus SRS alone, no difference in overall survival, but there was a difference in localized control rate. So these are all part of the battery of studies that show that the local control was not, the overall survival was better, not better, if you got whole brain radiation therapy. Okay. And here we go again. Similar data. Whole brain local control, whole brain better, but that did not translate into overall survival benefit. So that's often a question that's asked: is the overall control, is the local control better with whole brain radiation therapy? Yes. Is the overall survival benefit better? No. Okay. So here was a study or to see that looked at surgery plus SRS plus minus whole brain radiation therapy. There was less intracranial progression with the addition of whole brain radiation therapy, less neurologic death, but no difference in overall survival. And then we look at some single institution now, SRS plus whole brain radiation therapy. And now we're starting to introduce neurocognitive function. Okay, so in this single institution, it was started by Chang at MD Anderson. They looked at 1 to 3 Mets. Primary endpoint was not overall survival, was not local control, but was neurocognitive function. This trial stopped early due to increased neurocognitive function in the whole brain radiation arm. So we can look at here, this is the time course of cognitive decline. You can see that the SRS plus whole brain radiation therapy has significantly increased probability over the long term for neurocognitive decline, measured by highly validated tests like HVL, long-term recall. So we look again at Chang's study, and we look at the overall survival and SRS plus whole brain radiation therapy in terms of disease control and neurocognitive preservation. So the summation of this meta-analysis of randomized control of SRS plus minus whole brain therapy in 1 brain Mets. There are 3 trials that were used in this meta-analysis: the IOMA, Chang trial, and the RTC studies. Outcomes that were looked at were survival, local failure, distant brain Mets, treatment effects adjusted for the age, RPA, number of brain Mets, and treatment arm. There were 364 patients. 51% had SRS alone, and 49% had SRS plus whole brain. Okay, patients with less than 50 SRS alone favored survival. The omission of whole brain did not impact distant brain relapse. If you had 1 metastasis survive longer than 2 to 4 Mets and had lower risk of disease failure, SRS alone may be the preferred treatment for patients less than 50 and for 1 to 4 Mets. And this meta-analysis then went on to be tested as kind of this population in subsequent trials. So first of all, we looked at this trial, the N0574. This was a randomized phase 3 trial of whole brain, plus or minus whole brain, in addition to SRS for 1 to cerebral metastasis. Okay, so The primary endpoint was overall survival, and the secondary insight were time compared to CNS brain failure, quality of life, and post-treatment toxicity. These are nice. This is a nice study to know about because for lesions that are not perfect spheres, the previous dose escalation study may not be very good, and yet we're looking at here a volumetric dosing. So the results were published initially in abstract, and this has been made into a full paper by now, but the results don't change. So the cognitive decline at 3 months was more frequent after whole brain radiation plus SRS versus SRS alone. Okay, so there were differences in immediate recall, delayed recall, and verbal fluency. Intracranial decrum at 6 and 12 months were 66.1 and 50 with SRS alone. Okay, and 88.3 and 88.4.8 with SRS plus whole brain radiation therapy. That was statistically significant. The mean overall survival was 10.7 months for SRS alone versus 7.5 for SRS, okay, plus whole brain, so not significant. So the conclusion of this study has been completed and reported was decline in cognitive function, specifically immediate recall, memory, and verbal fluency was more frequent in the addition of whole brain to SRS. Adjuvant whole brain radiation did not improve overall survival despite better brain control. Okay, so this is really what's forming the foundation of what we do now is that we don't recommend whole brain radiation therapy, at least for patients with 1 to 3 cerebral metastases. And that envelope is being pushed more and more as the technology is becoming better for treating more than 3 lesions more efficiently. Okay, then we have another study that looks at SRS to the cavity versus whole brain radiation therapy. So it was a phase 3 study, N107C, a phase 3 trial of post-surgical SRS versus whole brain for resected brain mets 4 or fewer. Again, volumetric dosing. The SRS, some patients did have intact disease, even though they were getting their cavity treated. And notice here that the whole brain radiation therapy was, you could give it in 35, 37, 50, and 15, or 30 and 10 fractions. So what we learned from this is that there was no difference in survival, whether you gave whole brain versus SRS to the cavity. Okay, worse cognitive function. Okay, the surgical bed control was similar, although long-term was better with whole brain radiation. So the conclusion of this was for post-operative patients with resected brain metastases, they should be resected SRS should be the standard of care with equivalent survival, better preservation of cognitive function and quality of life, and less toxicity than whole brain radiation therapy. So one thing that has becoming to be challenged more here now is the management of brain metastasis in small cell lung cancer. We've moved away, obviously, and you probably will get some discussion of this in the lung section about the benefits of prophylactic cranial radiation. But we're moving away from that and more towards treating only patients in small cell lung cancer with therapeutically with close surveillance. But what about treating them patients with SRS for small cell lung cancer? It's really a paradigm shift, right? So this paper that came out a couple of years ago was a meta-analysis of 7 studies that looked at the use of SRS for small cell lung cancer, brain mets. So the overall survival following SRS was longer than for whole brain radiotherapy with or without an SRS boost or whole brain alone. Okay. But not whole brain alone plus SRS boost. Okay. Using single arm studies, pooled median overall survival from SRS was 8.99 months. Although between study heterogeneity was considered when pooled among all comparative studies. These results suggest that survival outcomes were equitable following treatment with SRS compared with whole brain in patients with small cell lung cancer and intracranial metastatic disease. So the idea is that you're not gaining that much in patients with a few number of brain metastases from small cell lung cancer by adding whole brain radiation or treating whole brain radiation alone. It is reasonable, and this is actually we have some more data from that, sort of poking at that question was a comparison of first-line radiosurgery for small cell and non-small cell cancer brain metastasis of the Crossfire study. So this is a multi-center first-line SRS outcomes where they looked at patients with small cell and non-small cell lung cancer from 2000 to 22, retrospectively collected. Okay, there's a ton of almost 1,000 small cell lung cancer and almost 5,000 non-small cell lung cancer. So they're looking at, if we think that it's reasonable to treat non-small cell lung cancer, is it not reasonable to treat small cell lung cancer the same way? So in general, overall survival for patients with non-small cell lung cancer compared to non-small cell and small cell lung cancer were fairly overall survival for patients with non-small was better than small cell cancer and lung. So they had people who have non-small cell lung cancer live longer than non-small cell live longer than small cell. Okay. Hazard estimates for the first CNS progression favoring non-small cell were similar in both data sets, but reached statistical significance in the retrospective data set only. In the prospective scored matched cohorts, there were continued overall survival advantage for non-small cell lung cancer patients, okay, and more so in the EGFR and ALK positive patients than without. Okay, neurologic mortality and number of lesions at CNS progression were similar for non-small cell lung cancer and small cell lung cancer patients. Leptomeningeal progression was increased in patients with non-small cell lung cancer compared to small cell lung cancer. So after SRS, small cell lung histology was associated with a shorter overall survival compared to non-small cell lung cancer. CNS progression occurred early in small cell lung cancer patients, but overall, but was similar in patients matched on baseline factors. Small cell lung cancer was not associated with increased neurologic mortality, number of lesions at CNS progression, or leptomeningeal persistence. These findings may better inform clinical expectations and individual decisions making regarding SRS for small cell lung cancer patients. So what this whole complicated retrospective analysis suggested that it's not so unreasonable to think about SRS for small cell lung cancer, although it has been often the mainstay for non-small cell lung cancer. Okay, so let me get ahead to here. We're actually looking prospectively to answer this question, and this I've moved this up here from the future attractions here is that we're going to look at a phase 3 study of hippocampal avoidant whole brain radiation therapy in patients with small cell lung cancer in 10 or fewer brain mets. So we will have this answer. we do have the foundation to suggest that it's reasonable, but now we have to test it. Okay, let's go back there then so now we're looking at limiting things that are used to limit the neurocognitive function in patients getting whole brain radiation therapy. So memantine was looked at in RTOG 0933 to add to whole brain radiation therapy. The reality of the situation is there's less decline in recall in the memantine arm. Okay, and there was less arm was significantly longer than cognitive decline. Okay, and there was higher executive function and processing speed and delayed recognition, okay, over time. However, these results were not statistically significant, although the executive function was these executive function and processing speed, but the neurologic decline differences were not seen in memantine alone. Although if you look at the NCCN, it is suggested that anytime people get whole brain radiation therapy, garden variety, they should get memantine. However, when you RTOG 0933, okay, looked at whole brain hippocampal avoidance, whole brain radiation therapy, and in this study they also added Namenda to this. So what important take homes from this study is that the hippocampus is contoured with an avoidance region around that, and the dose received to the entirety of the hippocampus cannot exceed 10 gray, the entire one. So the volume of the hippocampus less than 10 gray, and the maximum dose of 17 gray led to statistically significant improvements when compared to the historical controls in neurocognitive function. So this really is now the standard of care for patients who have multiple metastases outside 5 millimeters of hippocampus. And the study that proved that was RTOG 0933. So this is just a summary of the local control of these patients. You can see in Patchel 1 with whole brain 48, we said that this was an unremarkably high whole brain in 9508. In Paul Brown's study, 62%. We can see surgery alone, 46%. Whole brain with surgery, much better. Local control with SRS, really the best, okay, or very high. But the best still remains whole brain therapy plus SRS. But this, again, we talked about quite extensively, does indeed come with extensive neurocognitive defects. If we look at regional relapse, again, SRS has a pretty high regional relapse. It's not expected to treat disease outside of the SRS field. That's what you can come back with subsequent courses of SRS if need be. You can see that you can decrease the regional relapse with adding SRS to whole brain radiation therapy. But honestly, that does again come with neurocognitive defects. So in summary, the whole brain radiation therapy increases local control, increases distal control, increases functional independent survival, but it decreases the neurocognitive defect, the death rate, and decreases cortical serodependence. A choice of SRS versus surgery depends on tumor-dependent factors such as size, location, and accessibility, patient-dependent factors such as preference, prior treatment, and availability. Okay. The pros and cons of whole brain radiation therapy, again, improves outcome, widely accessible, no tumor restrictions, decreased need for salvage, it's cost effective, Its recurrence may be morbid and not salvageable. Recurrences may be morbid and unsalvageable. That's why you might want to go after subclinical micrometastatic disease. Late side effects are debatable. Delayed RT may worsen overall survival. The cons of whole brain radiation therapy include late neurologic and neurocognitive defects, delays in other systemic therapy. So if you have to wait, 2 weeks before you start systemic therapy, that's seen as a detrimental thing. Improved neuroimaging detects smaller lesions earlier. So, maybe we don't need to prophylax against subclinical micrometastatic disease, because if we are diligent about our surveillance, we can catch those disease earlier. Okay. There is however, no overall survival benefit. And that opposed to this delayed, there are studies that delayed RT may not worsen overall survival. So that's kind of a crapshoot there. Really, I mean, whole brain radiotherapy has formed a staple of what we do, but that does not mean that that all patients are candidates for it, and that we should not seek out alternative treatments for our patients. So again, 1 to 3 METs, SRS, dose for this, dose guidelines are all summarized on this sheet here for you. So this was the data that looked at short course versus long course. Basically looked at 20 versus 30 versus 40 gray, and there was no significant association between whole brain radiation therapy and survival. Whole brain with 20 gray and 5 fractions is preferable for most patients. Okay, so future questions here. Okay, pushing the number of metastasis, we just talked about that one. How about radionecrosis? So one thing that we didn't talk about too much was how likely is radionecrosis. It may be, symptomatically as much as 5 to 8%, maybe even more with the use of immunotherapy, and it may be radiographically much more common, and that is always the bane of our existence. So the Alliance study looks at control and radionecrosis, looking to give single fraction versus multi-fraction. There is some suggestion that multi-fraction regimens might get superior disease control and have less whole brain less necrosis. So depending on the cavity size, up to 30 cc's, you get 27 gray in 3 fractions, or larger than 30 cc's, 30 gray in 5 fractions. The Anergy BN012 looks at 1 to 4 brain metastasis, and they're looking at pre-op versus post-op SRS. That's a new and exciting concept. The idea is that when the surgeon goes in, he may be spreading cells along the dura and into the a situation where the cells may start to seed the CSF, and patients are then going to develop leptomeningeal disease. The real question is can we, if we give preoperative SRS, can we decrease the likelihood of leptomeningeal dissemination by giving that upfront? It's a compelling picture. We're seeing more and more leptomeningeal disease, whether that's a function of leptomeningeal disease being a final common pathway that unfortunately we never saw, because people's systemic disease took them away before the leptomeningeal disease reared its ugly head. But that is a question. So that's really what I have here now for the first portion of my taming. I'm going to talk about leptomeningeal disease because there's some interesting developments in the management that have come out, but I have that in tomorrow's section for palliative radiation therapy. So I guess at this point, I have a few minutes here that I would like to extend to you guys to go ahead and ask questions. I don't have any questions prepared because I don't necessarily think that this forum is having people read and answer the question, although some people might like that. It's probably not the most efficient way of doing so. At this point, I'd like to turn it over to people if they have specific questions about anything that I've talked to at this point. If you have something that's bothering you and want to put it in the chat, I promise I will read it out and then answer it. Lots of material, and like I said, some of this stuff is cataloged here in a way that I would hope that you guys could use it in subsequent years. Questions that they might ask, like, what does FLAIR stand for? How do you use? I didn't we speak of the MR and perfusion imaging again, because I think that that whether you're looking at pseudoprogression or radionecrosis as a function of SRS in brain metastasis is really no different than that question that you're asking for of pseudoprogression in a primary brain tumor, and so that's why it's kind of included in the overview instead of stuck in duplicate or in tandem in the whole brain and the primary CNS. I think this is instrumental for for dosing and setup. So someone has asked, how do you account or include for brain mets with focal dural involvement? Do you add a larger PTV with LINAC SRS? So that's a good question. So first of all, it's not really stated as if you mean resected brain mets or intact brain mets, but I think that if you're saying focal dural involvement, that's suggesting that it's a pathologic diagnosis. Generally, for resected metastasis, we in treatment planning, we use the preoperative MRI, and if it's touching the dura, we're usually giving being a little bit more generous along that dural margin. I think it's nuanced with respect to the using the preoperative images. How much contact did it have with the dura? By definition, the penumbra of LINAC-based SRS is not as sharp as Gamma Knife, and so there may be a bias towards, for at least for me, when I treat postoperatively, I don't often treat with a Gamma Knife because I think that in general the easiest way to think of it is that a LINAC is smudgier, and even though you may not be getting your full dose, at least along that dural that it's at risk, even if you don't include it in your say CTV, which I think I would include depending on the case, there is less steep dose fall off, and so you get kind of a bath of dose along that dural. But again, this is an interesting question because we're looking to solve that with preoperative SRS, and again, we don't really have a lot of data to suggest the optimal margin along the dura for preoperative. Another question that can be asked is, do you cover the surgical tract in a post-op SRS case? And I think it depends on how reasonable that tract is. There is data on this, and I think that if it's a small tract that's easily engulfed, but if it's a deep lesion and a big tract, I don't think it's reasonable especially if you're using preoperative imaging. And again, a lot of this nuanced stuff that I'm talking about now is more for next year than it is for this year. Knowing that but whole brain radiation therapy, in addition to SRS, improves local control, but does so at a cost. Those are grandiose concepts that you would be expected to walk away from this review session with and be able to answer on the written exam. It will be all over, I guarantee you, unless your brain thinks radically different than mine, that this is the easiest one. It's a lot easier for me to say easy, that I'm not sitting for it, but trust me, you guys will do well. People who have taken this course have done well, and a lot of us have done this for a long time. So if the material that we were presenting was not good, I'm sure we'd hear about it. Anybody else?